Welcome everyone to the EASL Studio, EASL's weekly broadcast news. And I'm delighted to be joined today by an expert panel because what we are doing this week is, today is the last day, I believe, of the World Antimicrobial Awareness Week. And as part of this important topic, what we're actually going to be doing is discussing about rifaximin. And of course, many of you are familiar with rifaximin for the treatment of hepatic encephalopathy. And what we want to do in the studio today is to discuss how we balance the benefits versus the risks in an area of antimicrobial resistance. So my expert panel in the studio today, who I'm going to now introduce, will include Professor Rajiv Jalan, Professor Jonel Trebicka, and Dr. Vishal Patel, all who are experts in this field, and I'm hopefully going to have much to add to the discussion and the debate. So what we're going to do over the next 30 minutes is really have an expert discussion in how we manage patients with cirrhosis and how they can continue to derive the benefits from antibiotics like rifaximin, whilst we think very carefully about how we also manage the risks of antimicrobial resistance. So welcome panel, it's lovely to see you all. And maybe just as a bit of a warm-up here, I can ask you really, why you think this is an important topic? Why are we here today to do this? Shall I come to you, Rajiv, to start with?
Yeah, thank you, Debbie, and thank you for putting this amazing studio together. It's extremely relevant. I think it's probably one of the most relevant questions in the cirrhosis world today, because as we know, most of the deaths that occur in patients with cirrhosis is from infection. And the occurrence of antimicrobial resistance or infection from MDR organisms underlies that squarely. And therefore, the discussion today is probably even more appropriate, given the fact that we are using more and more rifaximin in clinical practice. And that is despite the fact that there are several negative clinical trials recently. The Liver Hope is the best example, the recent study by Thierry Thévenot, the study from India in ACLF patients with rifaximin. They all highlight that we are using rifaximin more and more. And on the other side, there is this real amazing paper from Turner Nature, which starts to point really for the first time at the negative effects of rifaximin on driving daptomycin and vancomycin resistance, which is our last go-to antibiotics for this patient population. So therefore, I think we have to rethink where we use rifaximin, how we are using it, and how we can do better than what we're doing at the moment.
Thanks, Rajiv. And I mean, when the BAS trial was first published in 2010, and we were able to use rifaximin for hepatic encephalopathy, it was a bit of a game changer for us all, wasn't it? In terms of having something additional that we could offer to these patients that are coming into hospital all the time. So, I mean, how do we navigate that? What's your perspective on this?
Yeah, to be honest, rifaximin is already a key player in the treatment of hepatic encephalopathy already in Europe, at least in my perspective. Of course, the data are very strict. They show an additional effect added to lactulose. And this is something that has been already underlined in many guidelines. Nevertheless, the physician, they tend to make things simpler. And they tend to withdraw lactulose because lactulose brings some GI problems and so on, and they tend to go only for rifaximin. But nevertheless, the data do not support the use of only rifaximin in these patients. So rifaximin was a game changer, or is a game changer in patients with hepatic encephalopathy. Yet we have to really select them and treat according to the guidelines. So this is very important because rifaximin is not the next aspirin. I mean, Rajiv already said that there were several negative trials. There are several trials, also very, very well performed trials, randomized controlled, double-blind placebo-controlled trials with biopsy. For example, the trial by Israelson in alcohol-related liver disease. They do not show a clear benefit. They show less inflammation, surrogates of benefit, but it's not real clear clinical benefit. For this reason, it is a double-edged sword. But I have to say that for hepatic encephalopathy, rifaximin is really has been a game changer.
Thank you. And Vish, I know you've recently published some amazing work in Journal of Hepatology around antimicrobial resistance in the cirrhotic population. And as Rajiv says, this is a population that are very vulnerable to developing infections, and they actually are exposed to lots of other antibiotics as well, not just rifaximin. What's your take on how we get around that?
Yeah, thanks, Debbie. So firstly, it's a huge pleasure to be here with Rajiv and Jonel discussing this, and I agree this is a really important topic. I think the sort of point that Rajiv makes about infections and our recognition in cirrhosis that this is a real issue and it's an increasing issue can't be understated. So a lot of the work that we've been doing over the last few years is very much focused on how do we, prevent decompensation, how do we manage these patients more effectively. And the one thing that, you noticed that when we're looking after these patients clinically is that we reach for antibiotics immediately when they turn up, not even when they've got into a bed in the main hospital, they're still in the emergency department, because we know that the risk of mortality increases significantly with every hour that antimicrobial therapy is delayed. We are very behind on the diagnostic side. And to the more recent data that's been generated from a microbiome perspective, we have, with others, several others around the world, demonstrated a significant increase in antimicrobial gene burden in the sickest of the sickest patients. And actually, there's a stepwise increase in not just the gut microbiome, but also what we're seeing in the mouth. And there's a frightening kind of movement of these antimicrobial genes between those different cavities. Whilst we think that that's a great place to potentially be thinking about targeted therapies, which are non-antimicrobial related, and obviously there's fecal transplant trials, Debbie, for example, that you're running, and other approaches, Rajiv's carbon sort of therapies, knowing that we need to move away from antimicrobials as a sort of cornerstone of managing these patients. Ultimately, what we're now starting to see is, the potential risks of using the treatments we have. And I think, we are in a better place now than we have been, because actually we have better understanding from a sequencing perspective. So the techniques which are more molecular based allow us to get into this rather than using the slightly dated culture-based microbiological techniques. And that's really where the Turner paper comes in as a tour de force. But of course, we need to think about this in the context of the patients we're looking after and how translational that data is into the patients that we have responsibility for.
Yes, no, thank you. And I guess we've all got huge clinical cohorts that we manage and have been managing on rifaximin for many years. I mean, do you think we've got enough data to show safety? What's your thoughts there?
I think on the safety side, I think the biggest issue at the moment is that the Turner paper would suggest, significant concerns, and we can see where that's coming from. But actually, we're not seeing these sort of biological signals in the patients we look after. So, when they are admitted, we're not getting signals from the labs that they have these sort of daptomycin resistant genes developing, which is really what this manuscript is talking to. I mean, there's no doubt, obviously, that VRE is a huge issue in terms of Enterococcus faecium, and that's a bigger issue than ever now, particularly affecting the gut of these patients. And we're seeing that not just clinically, but also mechanistically in all the microbiome data that we're generating. And of course, MicroPredict will be, a huge contributor to that, because obviously there's big cohorts there, which Jonel is leading on, which will hopefully allow us to get a better understanding. But I think we are at an inflection point now where we have to be better at using the tools we have and mitigating for those risks. And at the moment, I think the safety profile looks reasonable from a clinical perspective, but it's only as good as how far one goes digging for these things. And I think we just haven't dug far enough. And those longitudinal data sets will really be what we need to now interrogate much more in a much more sophisticated manner.
Thanks, Vish. I think that's really important. And I'm going to come back to you. I mean, we've also been using rifampicin. Rifampicin is a relative of rifaximin, and we've been using that for a long period of time to treat things like TB. And again, we haven't always seen some of these worrying changes in that group of people either. So do you think actually there could be other things at play here? Potentially, it could be that they are getting exposure to different antibiotics at the same time. So that could be driving AMR. What are your thoughts around that?
So to be honest, it is difficult to see, but also it is like the discussion about the climate change, Everybody sees the signs, but the question is when will it come? So we don't really know at the very moment when we will have a big problem using all these antibiotics. For sure, it is incredibly important to use antibiotics. As Vish said, every hour we delay the antibiotic use costs patients' life. On the other side, we have to really be very aware that, for example, in patients with TB, this is a completely different population of patients at the moment, at least, compared to the cirrhotic patients. And the cirrhotic patients, we looked, for example, to telepressin, and indeed there are data out there. We looked over 1,000 patients, and we also investigated and demonstrated that telepressin alone is a risk factor for development of antimicrobial resistant in the gut microbiota gene pool. So we have antibiotic inactivation genes there. So I think the problem in our patients is that they have a very poor microbiota in general, because they are very advanced, so their diversity is very low, and therefore everything that we use with these patients, all drugs that we may use to these patients, they may induce changes. And I think it's also not, this is not a, I think this is not, it's a causality, and it's not just by chance that in cirrhotic patients, the daptomycin resistant genes were found. And this was in this paper by Turner et al., as Rajiv said, this was strictly in vitro. These were biospecimens. So it was not, so we don't see an overt clinical problem, but we don't know, or at least I don't know, whether we will see it in the future. Nevertheless, I think that so far we do have rifaximin for specific indications. So we have to stick to these indications and not do this for everything. And indeed, rifaximin seems to be a rather robust and rather a more inert antibiotic, and having little changes in the microbiota. As you showed, you can investigate the changes only by metagenomics. In 16S, we see very, very little. So in terms of effect on the microbiota, seems to be less than other antibiotics. So in general, I think we have to be aware that we are talking about a very vulnerable population. And in MicroPredict, we are looking forward to see whether we can find markers to identify patients that may benefit from rifaximin use. And we hope we can give better guidance.
Thanks, Jonel. And actually, it's probably quite a good point to come in now. So one of the things that we did in the prior to this studio being aired is we asked a poll on social media platforms for EASL on how our membership and listeners are concerned about rifaximin driving antimicrobial resistance. There were three options. One was that people could say they were very concerned and we should act now. There was an option B, that people were moderately concerned, but the evidence is just not quite there yet to make that call. And the third option was that people were not concerned and that clearly benefits outweigh the risks. And by far the majority, almost 52%, went for that option B. So there's concern, but the evidence is lacking. I mean, what do you think about that, Rajiv? What's your thoughts from that poll?
I think it's a terrific poll, because I think it reflects that a single paper, which is published in a high impact journal, which is focused on a particular question. And I think that is worthwhile looking at that paper for a second or two, because it specifically looks at the effect of rifaximin in this system, and it shows that it is associated with changes in these genes. And I think the important question for me is that the general public or our colleagues have picked that up and are expressing concern, exactly as we are discussing here, that it is a very relevant question about which patients do we use rifaximin in, because we can't stop using rifaximin. As we have heard, it is a very useful drug for patients with hepatic encephalopathy. But of course, we have to start thinking, when do we stop? So for instance, let's say if a patient is walking into the door with recurrent episodes of HE on rifaximin, is it the time to stop? Remember, the initial trial was done only over a 6-month time frame. And although we had taken that data to say patients are now going to be on it for a long time, and does that make a difference? And I don't know the answer, and there are better microbiome experts in this room than me, but I think they are expressing concern, our audience are expressing concern that we need to be careful about how we use rifaximin. We need to modulate our guidelines in a way that tells people that, look, be careful, because an antibiotic is an antibiotic is an antibiotic. It may be a little friendlier antibiotic, but we should not be throwing it around, because these patients, even if they come to a transplant, die from infection after a transplant when they get infected with these MDRs. So fundamentally, I think we just have to be more careful, which is what the people are saying to us. Don't use it like a sweetie pill. Well, it's not going to do any harm. If there's an indication, of course, you need to reach for it, use it, but define clear starting and stopping rules in your clinical practice.
Thanks, Rajiv. And Vish, do you have any stopping and starting rules in your practice? You're in a busy ACLD clinic, aren't you? Where you see lots and lots of patients with decompensated cirrhosis. So how do you approach this?
Yeah, I couldn't agree more with what Rajiv just said in terms of that discipline around how we use the medication. So, you know, the randomized controlled trial from Patel, you know, there was a lactulose component there. And I know we reach the rifaximin frequently, with particularly when patients don't tolerate lactulose. That's often a reason, isn't it, that they have to have second line therapy because of intolerance from a GI side effect perspective. But actually, most of the data which suggests that actually rifaximin is more effective when combined lactulose. The other point then about sort of are people responding? So again, having that discipline in the clinical setting to ensure that we're reevaluating our patients and taking that time and diligence to go through the history to make sure that you evaluate their response clinically. And we know that's very difficult in a busy clinical setting when we're time pressured, but also never forgetting how helpful and important it is to speak to their caregivers, because actually often it's the caregivers that will really give you that insight into whether they responded and not the patient themselves, because often they're unaware of what's going on by the very nature of the condition. But I think it's then identifying those patients who are not responding, and then having that sort of discipline to take them off the medication, and having a kind of rounded discussion around why that's happening, and thinking about other options, because again there are other options to manage encephalopathy with different centers would do different things, but looking at shunts, closures, and of course transplantation options. So we are naturally going to be reaching for pharmacotherapies because that's often the easiest, and that's what patients are asking us for. But when we know that they're not working, then we shouldn't just continue them, because in some certain circumstances medications will not have a signal and a potential risk to the patient. But with antimicrobials, we know that you drive resistance exactly by exposing people and their microbiome to those medications for a period of time longer than we would have done. And that's the perfect situation then to get those genes to start being selected for.
Thanks, Vish. And I mean, one of the things that work from many experts in the field, including yourself, but Jaz Bajaj has also published quite a bit of work to show that actually even at baseline, many of these patients have genes that suggest that they've been exposed or may harbor antimicrobial resistance. So, I mean, how do we factor that in? So they may even have genes before we even start
that's the
treating them in the
point.
clinic.
So the history of the patients is so important, because we don't know what happened before. If you see them for the first time, and maybe they had a lot of drugs in their medication before that. For example, there is another Nature paper from the group of Per Borg showing very nicely that in vitro, the non-antibiotic drugs which induce antimicrobial resistance, one of those is metformin. But if we go back to metformin, metformin has shown incredibly good performance in our patients, in specific cirrhotic patients. So I think it's very important to differentiate between this. And if we come back to rifaximin, in the beginning, when rifaximin started, when it came into the recommendation, in addition, a second line after lactulose, we had problems that the general practitioners continue rifaximin. So they usually, you discharge the patient, or they are out of your outpatient clinic, and then they just stopped rifaximin in this patient, and they come back with a HE. Now we have the opposite. What we see is that we discharge the patients, you stop rifaximin because, for example, there is no ascites, no hepatic encephalopathy, the patient is going very well, and they said, no, you need rifaximin, and then they get rifaximin. So I think the pendulum, we have to be aware, and this is how I interpret also the polls before where Rajiv was discussing. I think that what is clear is that we have the evidence is not enough to say per se that we are all aware that the patients have antimicrobial genes, and the rifaximin may increase it or may not. We don't know. Yet we should give rifaximin according to the guidelines and not use it as sweet, as Rajiv said, no, that's as sweets for the patients, because it does not do only good. It may also do harm, especially when they are so severe. But I get fully your point, Debbie, and I think it's important, but probably you are the best person to talk about this. What happens actually in the patients when they come in the hospital and they have so many genes in their gut? The question is, so many antimicrobial genes, what kind of antibiotics should we use to them? We cannot desterilize them, right? Because you are doing a FMT trial. So maybe you can discuss on that a little bit.
Yeah, well, maybe I could, although I think I'm supposed to be the moderator here. But I tell you what, I'm going to fire this back at Vish, because Vish, you've done some really nice work, haven't you, where you're looking at point of care testing for AMR, if I'm not mistaken. So do you think there might be a role that we could do more of that? So when patients come into the emergency department, we could actually use that as a tool?
Yeah, thanks, Debbie. So that's that work that we're doing at King's at the moment is part of the RIDIC study. So that's a rapid infection diagnostics in cirrhosis trial. That sort of leads on from a lot of the microbiome-based work that we've been running. So, as we talked about earlier, there are many issues around antimicrobial stewardship in terms of how we manage this, ranging from a One Health problem all the way to how we look at our patient pathways. And a real problem we've identified within that space is obviously around diagnostics and the fact that we're still using methodologies in the labs which date back from 20, 30 years ago. For diagnosed SBP, we're looking at white counts and microscopy. For culture-based results to tell us about sensitivities and antibiotic resistance, we're waiting 3 to 5 days. These are significant period of times for our patients to be waiting for the right treatments. And by then they've developed organ dysfunction, they're in ACLF and potentially doing quite badly in the intensive care unit. So to that end, we've started to look at more molecular-based techniques. So we're using, for example, Oxford nanopore-based techniques for long-read sequencing to see whether we can learn from the sequencing techniques where we're doing, deep metagenomics for studies and microbiome evaluation to see whether or not we can use those techniques now to actually do rapid diagnostics. So part of that would be evaluating DNA extraction techniques, removing the genomic signal from the patient samples and seeing whether or not we can get kind of point of care testing set up and rolled out and translatable so that you get same day diagnostics. And to that end, there's three main questions. One is, can we identify more rapidly which pathogens are present, particularly if it's a polymicrobial infection, which we do get occasionally in our patients, number one, and that applies to blood-based samples as well as ascites. Number two is, can we see whether there's AMR genes present at that stage, and therefore we can go straight to second or third line therapies. But something that's been already discussed is there are also stopping rules. So it's not just stopping rules for rifaximin, but also when we have a patient that comes in with an acute infection, when do we stop the antimicrobials? So, but we often run them for 2 or 3 days longer than we probably need to, mainly because we haven't got the confidence to stop. Because again, these patients don't mount the normal responses in terms of infection resolution. So the idea is to see whether or not we can use molecular techniques and obviously harness and synergize with our microbiology colleagues. And I think one of the big learnings for all of us here as hepatologists, we need to be much better with working with the other experts in this space, particularly microbiologists, as well as obviously, the microbiome experts, because only through those sort of synergies will we start to move this forward and make things better.
Thanks, Vish. I'm going to come back to you, Rajiv, now. And I mean, when you again will be managing lots of sick cirrhotics who come in to the Royal Free, and many of them won't just be at risk of developing hepatic encephalopathy. They'll be at risk of developing SBP, ACLF, all of those sorts of things. I mean, how do you kind of manage the whole antibiotic kind of thing? That they may have already come in on an antibiotic that may protect them or may be for prophylaxis of SBP. They may be on something to protect them against HE. How do you kind of navigate that as a sort of a clinician, but also with your kind of research hat on as well?
So, Debbie, look, I think we have to acknowledge that it is very difficult. And I think that, the first of all, we have lost the quinolones from our clinical practice. So we don't have norfloxacin anymore. Ciprofloxacin resistance in our hands is 20, 30, 40% in our patient populations. We recently saw from the aseptic trial that cotrimoxazole was completely negative in all its domains, as Alistair has shown beautifully in a very large trial. And so therefore, we have to reevaluate what we are doing with secondary prophylaxis for SBP, which is the only reason apart from recurrent hepatic encephalopathy with rifaximin that we have. That are the only two things that we have. So I don't know what people are using for secondary prophylaxis of SBP, but we don't have norfloxacin anymore. We're using ciprofloxacin either daily with 40% resistance profile. So, but that's the first point to make. It's very difficult. We don't know what to do. The second is that we are very lucky at the Free, which I'm sure that most people in the audience don't have access to, that we have microbiologists at hand. And they are very good at telling us which antibiotic we can use when, because we have an extremely good system. And what we are doing a lot more, which is easy, clinically useful, and also practicable, evidence-based, as shown from Barcelona and the others, that a rectal swab is a very useful tool to guide us in terms of pure resistance profiles that are, that we need to think about in our patient population. So the patient walks in, they're okay, they have a complication of cirrhosis, you do a rectal swab, you know where you're at. The patient develops an episode of infection, you know what antibiotics to reach for. So a directed therapy with discussions with your microbiologist, particularly for the sick people in terms of starting, changing antibiotics, stopping, is an extremely, extremely useful tool. But of course, I'm cognizant that a lot of people don't have access to a good microbiologist setup, but that is how we work and is very, very useful. What is difficult, and I think it's already been echoed by you, Debbie, is that what do we do in the long term? This idea that people could be on antibiotics for weeks and months and years is now gone. We don't have those antibiotics left anymore. And at the end of the day, rifaximin is just an antibiotic. And what we are seeing with the Turner paper is not really surprising, because it is an antibiotic, and the bugs are going to get resistant to it if we expose them enough in the system. And therefore, be careful about using antibiotics. My message to everybody is to talk with your microbiologist about what antibiotic you reach for, and check your patient's, rectal swab, because it'll give you an indication of what you might reach for should your patient get infected.
Thanks, Rajiv. So stewardship sort of comes through there as being absolutely crucial. And I mean, what about research priorities? So we've talked, all three of us have talked about how we need better data. If you could write a study, or you had something you wanted to go to a funder, what would you be asking for? What do we need to do as a community?
Maybe I can start. So as you know, Debbie, Vish, have helped me with this. So we are trying to develop a non-antibiotic strategy that could implicate on antimicrobial resistance. It's in the very early phases of development, but it's an adsorbent, very simple adsorbent, has really tremendous effects on the bacterial biofilm. But of course, we need to generate data to see where it fits. But of course, FMT or a phage therapy, which many people in this audience are working on, could be a way forward. So we have to think about new solutions as microbiome therapeutics. And unfortunately, we don't actually have anything significant to hand at the moment.
Okay, thank you. What about the rest of the panel? What are your thoughts there?
Yeah, I think the same as Rajiv. We have it also. We have every week. We have our microbiologists. Actually, today, so we have our round with microbiology, and antibiotic stewardship is extremely important. And on the other hand, I think that the stopping of antibiotics, early stopping, is crucial. And to be honest, we need antibiotics. Without them, we cannot treat our patients correctly. And we need also the reserve antibiotics, which may be at risk if this climate change in terms of antimicrobial stewardship continues. And I think that we need to invest more in this direction. We have to find the right patients for the right treatment. And indeed, we also worked, or we published together with Javi Fernandez, the rectal swabs, and we find the same thing both in Frankfurt and as well as in Münster, that we have an extremely important burden there, which is rising over time. And we have less and less efficacy in terms of antibiotic over decades. So the question is, we need other strategies. We need to explore them in research.
Thank you. And Vish, I'm going to also sort of add in something here. So we're also learning that diet's really important for our gut microbiome. So we've talked about some of these really new, novel, sexy therapies that we can look at, but I also think just diet are important in cirrhosis, aren't they? Can you comment on that and why that might be an important strategy alongside some of the other things that we do?
Yeah, so I think nutrition is probably the one area that we are all criminal, and I use that word very deliberately, at neglecting. And that's not a deliberate problem. That's obviously what happens when patients become ill. They come to hospital. It's tricky, isn't it, to feed them and to make sure they get the right nutrition. But there's a huge amount of work that we need to do in this space because, our microbiome ultimately is only as good as what we feed it. And most of us will walk around the wards looking at what they're fed, and it's not a good look. So there's a huge opportunity there, and there's very nice approaches which are again more 21st century, where we can use actually more precision-based nutritional approaches, take into account the difficulties that patients have in absorbing and tolerating food and the different macronutrients. So I think that's one huge aspect and a big area that we should be exploring much more aggressively. And actually, I'd like to see sort of combinatorial therapies come through. So not just what can we do from a sort of FMT or pre or probiotic perspective, but actually something that's much more precision nutrition based. And I put it out that that's something that we should all be responsible for trying to drive. I think going to your original question, Debbie, about sort of what next, I think for me, the clinical studies need to be much better about how we track rifaximin exposure. So not just sort of treatment duration, but also co-use of other antibiotics. We don't really understand how rifaximin is interacting with these. And then looking at whether or not in those patients who are longitudinally studied, and followed, whether this then actually translates into clinical infection. Because at the moment, there's a lot of discussion around colonization, which is really what the sort of rectal sort of swab sampling helps with, but that doesn't necessarily translate into infection. So that's an important difference. I think the other thing is around systematic surveillance. So we should be much better about reviewing with our microbiologists what's going from a surveillance strategy perspective, and then embedding that into our future trials so that we're collecting samples longitudinally, strain typing, and looking specifically at antimicrobial resistance genes, especially in our decompensated patients, and a lot more mechanistic work because we've got the tools. We talk about sort of a multi-omics approach all the time, but actually this is exactly the kind of space where we should be doing those longitudinal heavy lifting trials and studies and collecting those samples longitudinally and linking back to rich sets of metadata specifically around antimicrobial co-use, because I think that's an area that we don't really understand fully.
Thank you. Let's hope our funders are listening to this conversation. Can you believe we've been just, our time is nearly up. We've already been talking for 30 minutes, but actually I want to just come to one last aspect. One of the thing, another question that we asked our audience was about guidelines. And what do we do about guidelines in terms of rifaximin, but also hepatic encephalopathy, but also more widely in terms of cirrhosis? And one of the questions that we asked people was, do we need to make changes to guidelines? Do we need to keep them the same because we still need that extra evidence? Or actually do we need to start getting worried and thinking again? And again, more than 40% went for that we need to keep our current guidelines, but I think we do need more data. So I just want to maybe come to each of you just finally to get your take on what we do with guidelines. How do we advise our listeners who are, many of them who are clinicians, to manage this situation? I mean, can I come to you, Rajiv, first?
Yeah, so as I've said, I think that rifaximin is very helpful in treating patients with hepatic encephalopathy. So we absolutely must have them in the guidelines. But I think we need to be nuanced, that you have to know when you want to start, when you want to stop, and how to monitor patients that are receiving rifaximin is what I would add to the guidelines rather than take away rifaximin.
Thank you, Rajiv. Jonel?
So rifaximin, I think, has been discussed as a disease modifier for a long time. Currently, we do not have data to use this as a disease modifier, although there are negative, positive data, but the thoroughly performed data seem to be negative. So we cannot advise using it as a disease modifier, but stick to the recommendation of the guidelines according to HE in combination with lactulose.
Thank you. Now, and final word to you, Vish.
Yeah, no, I mean, I would echo very much what Nell and Rajiv has said, and it's just underpinning that discipline when we have patients come to clinic to reevaluate them, and if they're not responding, then to have a low threshold to discontinue and think about alternative options. And I guess the tricky thing for all of our patients is that the options alternatively are limited, which is why we are in the situation we're in. But we mustn't continue to expose them to a drug where they're not getting that that benefit. So to check clinically and ensure that they are.
Well, thank you very much. So I'm afraid it's time to wrap up now. We've been going for 40 minutes, but look, I'd really like to thank all of you, Rajiv, Vish, for a wonderful discussion today. I think we have made it crystal clear that we all need to be part of antimicrobial stewardship as clinicians and hepatologists, and always have that in the back of our minds. So thank you very much for joining me today. And just to remind the audience that please do become an EASL member. And to tune in for next week's studio, which is going to be summarising some of the exciting data and research presented at the American Liver Conference, the AASLD. So we'll be joined by a panel that will be summarising some of the highlights from that meeting. So thank you very much, all of you, and have a good day, everyone. Bye-bye.
Thank you, Debbie.
Thanks, Debbie.